Hi guys, welcome back to the Clean Scalpel. My name is Ankor Shukla, and as promised, we're going to continue with our ultrasound series, and today we're going to be talking about carotid ultrasound physiology. So without any further ado, let's get started. So as always, let's look at this first image here. And what are we looking at? We're looking at the right ICA. We have a waveform, we have some velocities, we also have color flow denoted here. And my first question to you, like always, is what does this represent? Is this a normal study? Is this an abnormal study representing a proximal stenosis? Is this an abnormal study representing distal stenosis? Or is this an abnormal study representing distal occlusion? So take a second, think about it. It's the right ICA. And yeah, for those of you who quickly said this looks pretty normal, you're 100% right. And we will get to the details of the other answers as we go through more questions. But let's break down this waveform. So the first thing you notice is that there's a sharp upstroke, just like in peripheral physiology. This represents increased velocity at the start of systole. Very quickly, you have a rapid deceleration, decreased velocity at the end of systole. And then interestingly, with the ICA, and this makes sense, is you have antegrade diastolic flow. And as we remember from peripheral physiology, this is a sign of lower distal resistance. And of course, the cerebral circulation is a very low resistance bed. So this makes sense. You want blood flow going to your brain at all points of the cardiac cycle. And again, this is a very easy representation of that simple concept. So with this in mind, let's look at the ECA. Okay, so very similar waveform, but there are some different nuances. So we looked at the ICA and the ECA. Again, sharp upstroke makes perfect sense. You do have rapid deceleration now, but something is different. You do have a reversal component. And what does this represent? As with peripheral physiology, it represents increased peripheral resistance. And this can also be seen by minimal diastolic flow, but it is higher resistance than the cerebral circulation, and therefore the end diastolic velocities, you'll notice, are much less. So the ECA. And so what do you think the common looks like? And we're working backwards intentionally because guess what? It's a combination of both waveforms, okay? Sharp upstroke. It doesn't necessarily have to get some reversal flow, but with a crisp spectrum here, you can see that. And then you do see some antegrade flow in diastole, again, which represents more of the ICA component than the ECA. So with this simple concept in mind, let's ask another question. So what does this represent? And these arrows are pointing to this right here. Is this a normal finding? Is this B, an abnormal finding, which represents calcific plaque? Is it C, an abnormal finding, which represents poor probe contact with the skin at that location? Or is it D, an abnormal finding which represents a hypogenic mass? So take a second and think about it. Yeah, so there you go. It is, in fact, an abnormal finding which represents calcific plaque. So working through these, normally without disease, you would not see this finding. Number one, if it was poor probe contact with the skin, in fact, the entire area above this location would be lost. Or is it a hypogenic mass? Again, unlikely in this location, but why is it in a cone-like fashion and goes right through the vessel? Wouldn't make sense. And so just by even some test taking stuff, it is calcific plaque, and this is called acoustic shadowing. The ultrasound waves do not penetrate the calcification, and therefore they're reflected back, and what that tells the computer is that there's nothing beneath or deep to that calcific location. Now, again, we're building on concepts, and so with this in mind, let's add one more concept as we go solve the rest of these questions. Okay, so what is the direction of flow of this vessel? And for those of you who have a hard time visualizing that vessel, it's this one right there. So take a second. Is it screen right to screen left, or is it screen left to screen right? And again, you can look at and understand some of the concepts which I've described. You do see that there's some acoustic shadowing at that location, which blurbs the middle of this location. So you have to imagine what the vessel may be doing. And yeah, so if you guys decided it was screen right to screen left, you're 100% right. This is in fact the vertebral artery. And these are transverse processes, and this is a very common view that you may see of this vessel, where you may see the acoustic shadowing blanket out the vessel here, but you can deduce that this, as it's away from the probe, is going in this direction, and blue here, it's towards the probe, is going in this direction. So what makes most sense is going from screen right to screen left. Now, if you also picked up on the fact that it was a vertebral artery, and you know from our previous lectures that in a longitudinal view of a blood vessel, the left side of the screen is always towards the head and the right side of the screen is always towards the feet, you know blood flow has to be going, particularly in a normal vertebral artery, from right to left. And again, you can see the transverse processes here, and that's what you're seeing in those previous images. So, a little bit more complicated question, but what is the direction of flow of this vessel? Okay, so take a close look at this. You can see there's a lot of different colors going on. Is it screen right to screen left, or is it screen left to screen right? Yes, and so again, it is screen right to screen left for some of the simple reasons we talked about. But this particular image has a lot of beautiful findings which are really important to understanding what's going on. So the first thing you notice here is, yes, this is blue here. It's going away from the probe. And then you see that this portion is red, which means going towards the probe. Okay, so it has to be going from screen right to screen left. But you notice something in the between those. You see a dark black line. Now, where else do you see that dark black line? Well, right here. So this concept, when it flips like this, is flow separation. Okay, it's representing the change in the direction of the flow, even though we know, or we can imagine that the blood flow is going in this direction, but this is what it visually appears on the ultrasound. Now, you notice here that there's some blue flow. Well, how is that possible, Dr. Schugle? Well, you can imagine as blood flow comes here, it's making a little eddy, and there's a jet going retrograde and then meets back up to go antegrade. So again, some kind of pretty pictures to give you some physiology as you're reviewing these things. Now, there's something else interesting going on here. So unlike this separation where there's a black line, you see there's a very bright line here. And what this represents, and for those of you who have seen it, when the PRF is not high enough to figure this out, you see color aliasing. So aliasing, not on the spectral waveform, but you can imagine that the velocities here are so elevated that it essentially goes on the other side of the spectrum, and this is a visual representation of that concept. And again, it's denoted by the white line, the extremes, as it flips back over to a different color and then back again. Okay, so some really interesting concepts just from a simple picture. So again, let's keep building on these concepts. What is the direction of flow in this vertebral artery? So you can see a lot of concepts being put together. You can see the acoustic shadowing, blotting out these locations, but you do see the vertebral artery. And if you said that this was a retrograde right vertebral, you're 100% right. You notice it's blue, it's towards the probe, so blood flow has to be going from screen left to screen right. Again, an abnormal finding. Now, the reason we've put all these concepts together is it's really important when you see something like this, okay? And to help you out, I will give you some labels. This is the external carotid artery, and this is the internal carotid artery. Which direction is the flow going? Can you tell me? You notice it's towards the probe here, and then away from the probe in this direction. So in fact, yeah, it's going in that direction. So why is that? Well, in this situation, the patient had an occluded common carotid artery, and the blood flow is actually going from the ECA to the ICA. So again, very interesting. You can see all the things we talked about in play. You can also see the small black line representing flow separation. So again, these concepts are really coming together here. So what does this represent? Now, what are we looking at? We're looking at the right common carotid artery. And remember what we talked about. Look at the other things that are given to you, the waveform, the velocities, and the color flow. So is this a normal waveform for the right common carotid artery? Is it B, an abnormal waveform representing inflow occlusion? Is it C, an abnormal waveform representing distal ICA occlusion? Or D, an abnormal waveform representing aortic stenosis? So take a second and think about this. So a little bit tougher. And so for those of you who said it was IC occlusion, you're 100% correct. So let's really break down this waveform. So tell me about the upstroke. Is it sharp? Yeah, it's a nice sharp upstroke, which points to the fact that you probably don't have any kind of inflow stenosis or occlusion, which would cancel out B and even D in this situation. So you're left with, is this a normal waveform or an ICA occlusion? And for those of you who are astute enough to look at the velocities, you may notice that the velocities are extremely low and the end diastolic velocity is essentially next to zero. And this really resembles what? Yeah, the waveform of the external carotid artery. And so this is only possible as the ICA is occluded and the common carotid artery essentially represents the waveform in the open external carotid artery. And of course, as we look further on, that's exactly what you see. You see that ICA is totally occluded with an abnormal common carotid artery waveform. Okay, so now we're comparing a few sides between the right and the left. Okay, so what does this represent? Is this a normal waveform on the right side? Is this B, an abnormal waveform on the right representing inflow stenosis? Is this an abnormal waveform representing distal stenosis on the right? Or is it an abnormal waveform representing aortic stenosis? Think about this for a bit. Look at the information given to you. Yeah, a little bit tough. But yeah, for those of you who found it, it is in fact the abnormal waveform with distal stenosis on the right. Now, so you're asking me, Dr. Shukla, how can I really tell? And I'm going to flip back to one more picture. This is the distal ICA. You notice that the waveform on here versus here, a lot of spectral broadening. You do see the velocities are very low, a little bit higher on the right side with more clear spectrum. But the way you know from this particular image is, again, look at the velocities. Significant difference in the ICA between the right and the left. You also notice the increased spectral broadening. But is this an inflow stenosis of any kind? No, because the upstroke is very, very sharp. So why would you then have decreased peak systolic velocities? And the way this is scaled, it looks like they're equal, but this is actually only a third of this one here. So there's a lot less flow going in that ICA. And in this situation, well, why was that? And when we examined this patient further, a CT of the neck showed that there was a dissection of the right cervical ICA just proximal to the petrous portion. And again, what you saw was a visual representation of lower flow to that side. Now, a lot of people say, Dr. Shukla, you're only seeing velocities, but you have to remember that if the integral of that graph does give you flow. So again, not something we're going to talk about today, but just as a big concept, that's what we're really looking at. And though the scale doesn't really do its justice, when compared with equal scales side by side, you'd be able to see the difference. A little bit of a series. So you look, there's the mid common carotid artery. There's the external carotid artery on the right side. And finally, there's the proximal ICA. Okay, so very similar waveforms throughout. Now, what I will tell you is that the left side does not look like that, and it's totally normal. So what does this represent? Is it a normal waveform? And maybe I gave that away to you. Is it an abnormal waveform representing distal stenosis on the right? Is it abnormal waveform representing inflow stenosis on the right? Or is it abnormal waveform someone with aortic stenosis? What do you think? So by process of elimination, yeah, so again, it does represent an inflow stenosis on the right. Now, if the left side also looked like this, you would obviously think a more proximal or cardiac etiology, so aortic stenosis, would be a more appropriate answer. But again, you notice that the upstroke is not sharp. This is a tardus parvus waveform. There's a decreased time to peaking, and this is a very, very important waveform to understand because it shows you that yes, there is a significant stenosis, and in this situation, because it's present throughout the entire side, it's probably very, very proximal, even more proximal than that. So you'd have to start thinking about what those locations may be. So running with this concept, let's look at this image, and I'm going to piecemeal it together for you. This is the bulb here in the ICA. You notice from previously, you see a lot of calcification in the acoustic shadowing. Much more distally in the ICA, you see that this is the waveform here with the velocities shown there. And then if you look proximally though, this is the waveform of the proximal common carotid artery. And the ultrasonographer says when she looked at velocities, she couldn't really find any elevated velocities at all. But there's clearly a lesion here, and I want you to tell me where that lesion is. Is the lesion in the right innominate artery? Is it in the right proximal ICA? Is it in the right distal ICA? Or is it in the right proximal common carotid artery? So think about this. Distal ICA waveform, the tech tells you because of the shadowing, she can't really find any waveforms there. And then the proximal common carotid artery. So yeah, this is in fact a severe lesion of the right proximal ICA. And guys, and this is a very, very important concept. Sometimes the numbers, especially when you're looking to quantify carotid stenosis, won't be there. And so unless you've actually looked at the waveforms, you may miss a critical stenosis that you may be able to help the patient with intervention. So this is really important. If you see a distal waveform, like here, that's tardus parvus, you have to assume that there is a lesion proximal to that. Now the right common carotid artery waveform looks very, very normal. So you have to assume it's in between the distal ICA and the common carotid artery. And again, the most common location for disease, as we all know, is the carotid bulb, which extends into the ICA. And so why can't you see it? Well, the calcification is blocking that. So again, very, very important concepts. If you really wanted to quantify it clinically, you'd have to get a CTA to see what it looks like. Now, there are several different diagnostic criteria. I would ask you to look at your training program and see what numbers they use. This is the one we used in my training program. And again, looking just at the velocities or just at the ratios, you can get confused, especially when you're looking at the ratios, because you really have to go look at the waveforms critically and make sure it makes sense before you give a diagnosis. Let's keep moving with the where's the lesion kind of questions. Okay, so look at this two images. So what you see on the left side is you see the right vertebral artery. Look at the information given to you, and then look at the right common carotid artery. Okay, and where is the lesion? Is it in the right innominate artery? Is it B in the right proximal ICA? Is it C in the right distal ICA? Or is it D in the right proximal common carotid artery? Take a look at the waveform in the look at the waveform of the common carotid artery, and what do you see? Yeah, so if you said that there is in fact retrograde waveform in the vertebral artery, you're right. And if you said that the common carotid artery looks more like a tardus parvus waveform, you're also right. And in fact, the lesion is in the right innominate artery. And so you're seeing proximal stenosis in both those vessels. So if you're having a hard time visualizing this, you notice here, stenosis here would have a tardus parvus waveform throughout the carotid circulation. And on this side, you would get retrograde flow from the other vertebral artery, which is what you see. Okay, so again, putting concepts together. So again, you're looking at the right vertebral artery, and you're looking at the right common carotid artery. So take a look, think about it. Where is that lesion? Proximal ICA, distal ICA, proximal common carotid artery, right innominate. Right, so the direction of flow of the vertebral artery really gives that away. So this is an antegrade vertebral. flow's going in the correct or normal direction. So in this situation, the lesion is in the right proximal common carotid artery. Right there, probably not able to visualize it, but again, you see that tardus parvus waveform in that right side. Let's do a couple more of these. Okay, so you have the right vertebral artery and the right common carotid artery. So take a close look at the waveforms, the numbers. And by now, I know you're getting the hang of it pretty fast. Exactly. So there is a lesion in the right subclavian artery. So you're having a retrograde flow in the vertebral artery, but a very normal common carotid waveform, which is only really possible with an occlusion in the subclavian artery, which preserves normal waveforms in the common circulation, but a retrograde waveform in the vertebral circulation. So you may also see something like this, and this is just a little bit of an Easter egg, no pun intended, because if you see a waveform like this, what does that really tell you? So for those of you who don't know or haven't seen it before, this is called the bunny sign, and that's why the Easter egg was no pun intended, but you do see a systolic upstroke here, and you see then almost a triphasic waveform with a lot of flow and diastyling. This is why this looks like this. But again, this represents a pre-steal waveform. And why would the vertebral be stealing? Well, this is before it flips to perhaps a retrograde flow, and that's because, in fact, there is a lesion in the subclavian artery proximal to that side. And how do you see that? Well, if you do an angiogram, you notice that there is a tight lesion here. Here's a vertebral. And in fact, when it's fixed with a stent, improved blood flow in the vessels. Okay, guys, and with that, I hope a lot of those concepts came together for you. And that is really it. I appreciate all your time. And again, if you have any questions, concerns, or things you want to discuss, please write them in the comment below. And other than that, we will see you guys next week for another Ultrasound Series lecture. Thank you very much.